Can you guys hear me? Am I mic'd up or, yeah? Okay. So today we're going to talk about evidence-based medicine. It's kind of the horcrux, if you could say, of everything that we do as pharmacists. So this is just a basic introduction. You'll be building on this each year as you go along on how to interpret studies, which is really a main portion of what we do when we talk about drugs, what drugs are better than another based on studies. So we're just going to give you a brief introduction today. I'm going to go through, I think we're going to try to have some fun. We're going to make a boring topic fun. Let me know if I've succeeded in that. And then I love SpongeBob. So SpongeBob will be on all the important slides that you should know for your test. So just a little hint to help you guys out for your exam questions that you have. Let's see if this will. We tried to dim them, but it dimmed the whole classroom. If you guys promise not to fall asleep, I guess we could do that. Or are there some that dim in the front? We can keep going, but these are kind of the learning objectives that I have, and my questions will also be written based on the learning objectives that I presented for you. It's off on the center. So the three main components that we'll talk about today with evidence-based medicine. Okay, never mind. All right. As long as all of us don't fall asleep. Oh, there we go. Much better, thank you. Okay, so the three main components of evidence-based medicine, we're going to talk through the hierarchy of study designs. So we'll look at a pyramid and see each study and the corresponding level of evidence that they have. That's kind of something that you'll see throughout your career, this same pyramid. Applying the PICO principle to formulate a clinical question. Also explaining generalizability and the questions that will help determine whether a study is generalizable or not. And finally, determining patient-related factors in a patient case that may lead to medication non-adherence. These are the things that I would expect that you should know for your test. Okay, so I know you guys are P1s, but I want you guys to participate with me. So I'm going to make you close your eyes for this one so that nobody knows what anybody else has answered. So please raise your hand if you would always recommend choosing a medication that has the best evidence. So close your eyes and raise your hands. Okay, open your eyes. I would say about 3/4 of the class said yes, that they would always recommend using a medication with the best evidence. I am here today to tell you that we do not always use a medication with the best evidence, and we're going to talk about it and then see if you change your mind by the end of the presentation. Geez, I gotta point it over this way. Okay. So the definition of evidence-based medicine: the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of the individual patient. It means integrating individual clinical experience with the best available external clinical evidence from systematic research. So my question to you would be, based on this definition, can you pull out what you think may be the three main components of evidence-based medicine? Go ahead. So you're saying integrating individual clinical experience. So clinical experience is one part of evidence-based medicine.
External evidence from research.
So evidence from research, so your systematic research, and one more. The individual patient, exactly. So those are our three that we look at. So it's not just what's the best evidence, but also what does your clinical expertise say? What does your experience as a pharmacist or a practitioner tell you to do with this patient, and what may be a best choice for a medication? And then what is the actual research? We do need to be cognizant of what is the best evidence so we can make a good recommendation for our patients. So what or who is involved in evidence-based medicine? If you look on the left, we have the evidence portion of it. So anecdotal. Right? So this kind of comes into your clinical expertise. So there's a story. So maybe something happened when you were a pharmacist, you saw a side effect happen for a patient, and then you see another patient who's very similar to that patient, and you say, hey, maybe we shouldn't choose that drug because it caused a side effect in someone else. So that's kind of your anecdotal. There's really no basis behind it, right? It's just kind of the story, something that you've seen in the past. Then there's clinical trials. So drug companies all create clinical trials to get their drugs on the market. So we look at those in order to determine what's the best evidence. They'll also sometimes study one drug over another drug. And we'll see, okay, which one is better in whatever outcome that they look at. A systematic review is doing a literature search. So that is actually taking a broad look at multiple studies and seeing what you think when you combine all of those studies together. So what does the group of studies really tell us is a better choice? Because maybe one study isn't good enough to tell us that one drug is better than another. Then you have the medicine piece, and that's us, right? So that's pharmacists. We make clinical decisions every day as pharmacists. That's medical professionals, whether that be a physician, whoever's taking care of the patient, a respiratory therapist. And patients themselves are involved in their own care. If a patient decides not to take the medicine, then all your research didn't really matter, did it? Okay, so here's SpongeBob. Components of evidence-based medicine. So like we said, the three components would be your research, clinical expertise, and your patient values and preferences. So it's important to know this. All right, so now we're going to talk about the research component. So SpongeBob and Patrick are on a mission here, and we're going to join them along to learn about research and what we should do in terms of research. So here's the pyramid I was talking about. The power of evidence. So when you see at the bottom here, this animal research would be your lowest level of evidence, and your meta-analysis is your highest level of evidence. You will see this pyramid over and over and over as you go through school. So we're just going to kind of go through the basics of what the studies are and why one may be better than another. Okay. So we're starting kind of at the bottom. I skipped animal research because we don't normally talk as much about animal research. It's not as generalizable as we'll learn to humans, right? You can't really relate necessarily an animal to a human under most cases. So we're going to start with these case series or case reports. So a case report is something that happened in one single patient. So someone wrote a report about a side effect or something that may have happened in one patient that they saw. So there's no one to compare this to, right? So that would make this a little bit lower on the level of evidence that you would think. You're not really comparing anything, you're just talking about one patient. And you can't make any associations. So you can't say that for every patient like this, this is the way it's going to be. Or that this drug actually causes this. Or that it's likely that this drug causes this. You really can't make any association with this type of report. A case series is the exact same thing, but it's multiple reports. So it's just that you have a couple of patients where you've seen this happen. We actually just had patients, cystic fibrosis patients, who had a line. So they've got a line that goes in their throat here. And cystic fibrosis patients don't normally clot their lines. So it's common that you'll see other patients clot their lines. But these patients, 3 of them in the last year, have clotted this line. Seems strange. So now we've decided, based on that, to anticoagulate them. So to give them something so that they may not clot that line. Is that based on any evidence? No. That's based on essentially a case series that we've seen. Multiple patients have done this, so we're doing it to prevent it from happening in other patients. So again, there's no real comparator group. You're not comparing to another group that didn't have this happen to them. And you can't still make any associations with these. So these are kind of the bottom level. This is when you start to see something and you're like, hey, maybe there's a pattern here. Maybe I should introduce this to the literature and see what other people have seen. So next, we're going to move on to case controls and cohorts. So your case control compares patients with the disease to those who do not have the disease. So here you're making more of a comparison, right? So that's why this is a little bit higher on the evidence level than your case series and your case reports. However, this is observational. So we are not making an intervention. We are not giving someone this or giving them a placebo. We are not doing any of those things here. We are just looking at a group of patients and comparing those who have the disease and comparing those who don't. So we cannot say that X drug causes some side effect. We can say, yeah, there may be a link, but it may be that, okay, so now I give you this drug, and then it causes you to be sleepy, and then it causes you to fall, and then it causes you to fracture. But do we know that it directly causes a fracture? No. So you can make an association that eventually it will lead to a fracture, but we don't know if it's a direct cause and effect. So that's what that means by association versus that you can actually make a cause and effect relationship. So a cohort, on the other hand, is you are identifying a group of patients with an exposure. So they've been exposed to something, so some drug you could say, and then you're following them over time and seeing if they develop this disease or this problem or whatever you are studying. So it's a little bit different from the case control, but they're the same in that they're both observational. We're not giving them anything, we're not doing an experiment, we're just following them and seeing where they go. Again, you can make those associations, but you cannot make a cause and effect. So you cannot say that such drug causes such side effect. Does anyone have any questions so far? Make sense? Okay. So now we're going to move on to the higher levels of evidence. So your randomized controlled trials. So all of our drugs usually that come out are randomized controlled trials. When they come onto the market, the FDA requires them to have a randomized controlled trial. We'll also go over systematic reviews and meta-analysis. So a randomized controlled trial is, okay, we're comparing one to the other. So they're getting one or they're getting the other. So it could be drug A and placebo, or it could be drug A and drug B. But you're comparing two things that you are actively giving the patient. So the key word is an intervention. So you are doing an intervention on this patient. You are not just observing them and following them throughout time. So this really looks at real patients and looking at the effect of whatever you may be giving, the drug, whatever type of treatment to the patient. Systematic review, I already touched on a little bit. This is when you take a whole big group of studies that have been done and you do a systematic review. So you look at all the studies and you make conclusions based on the studies that have been done. So you say, hey, 5 of these studies showed that drug A actually lowers the risk of cancer in these patients. So I would say that that would be a higher level of evidence than a randomized control trial, right? Because your trial is just one. Your systematic review is a pile of trials that you've come together and you've made a conclusion about. Meta-analysis takes that a step further. So meta-analysis is the same thing. You take a big pile of trials together, but when you take that pile of trials, they actually run statistics on them. So they do a whole statistical analysis to see if the drug actually is better. So that is a much higher level of evidence because you're using multiple trials. You're not just making conclusions on your own. You're actually running additional statistical tests to show one way or another that a drug is beneficial. Does that all make sense? And all 3 of these can make that cause and effect relationship. So you can say drug A causes this. Does that make sense? All 3 of these. So that's kind of the pyramid and how it moves up, and we'll talk a little bit about it and be able to apply this later in the lecture. Okay, so how can we use good evidence to help make a clinical decision, right? We just talked about studies, but how are we going to make a good decision based on these studies? So there's 5 A's of evidence-based medicine: assess, ask, acquire, appraise, and apply. And while we go through these, we're going to go through examples so that it makes a little bit more sense. So you guys are going to have to get out your thinking hats and work with me a little bit. And there's SpongeBob again. Okay, so assess. So really you're looking at a clinical question and you're assessing it. So there's a case. Someone comes up to you in the pharmacy, whatever it may be. So your case arises and you have to decide, okay, what am I going to do about this? Happens all the time as a pharmacist. Who's had this happen as a pharmacy intern? It happens all the time, right? Somebody comes up with any question and you've got to figure out an answer. So here's our case. An elderly African-American man walks into Smith's pharmacy and uses the blood pressure cuff. It's 158/94. And you, as the astute pharmacist, repeat it and get a blood pressure of 154/92. He recently started taking lisinopril instead of the amlodipine his doctor used to have him take. He wants your opinion on which medication is better to lower his blood pressure. I know you guys have done blood pressure, so there's no backing down on this one. Okay, so how do we construct a question based on this case? So PICO is the acronym that we use. So this is something that you should know for the test. So P, your patient problem. So what is the actual problem that the patient presents with? So we'll go over this case in a minute. I is the intervention. So what are you intervening with? So what is the new drug, essentially, that we're using for this? Or what is the exposure? Usually it'll be an intervention. C is your comparison. So what are you comparing it to? And then O is your outcome. So what are we looking for as the outcome in this patient? So if we go through this example, P. So our patient is an elderly African American male with hypertension. So that's the patient problem, patient scenario, right? We need to be specific. So we need to know that this is an African American patient. That makes a difference, right? And sometimes in what we would recommend for blood pressure. Elderly. That makes a difference in what our goal is for our blood pressure. So it's important to include those things and the fact that he has hypertension. So the intervention in this case is lisinopril. So that's the new drug that he might start taking. So C, what is the comparator? So in this case, the comparator is amlodipine. So we are comparing it to the amlodipine that he was previously taking. And then O, our outcome is the lowered blood pressure. So what is actually going to help with lowering his blood pressure? So based on that, you create your own clinical question. So you kind of just take everything and smush it together into one question, right? So in elderly African American patients with hypertension, is an ACE inhibitor, lisinopril, more effective than, I don't know why that says beta blocker, calcium channel blocker at decreasing blood pressure? So does that make sense? So you just kind of put all the pieces together to create your own clinical question so that when you go to search the literature, you know exactly what you're searching for. This is what this helps you with. So we're going to practice one on our own. So here's your case, and you guys can work together in pairs of 2 or 3 for a couple minutes and come up with your PICO and then your clinical question. Go.
And I like when I was going in the dictionary, kind of like the.
All right, if you guys are finished, thumbs up. Thumbs up in the back. I can still see you in the back. Is it finished? Okay. So would we like to have any volunteers to go through their P? What was their patient? Go ahead.
I said a 3-year-old female with an ear infection.
All right, let's see. What do you guys agree?
Yes.
Yeah, so 3-year-old, right? Pediatrics with the ear infection, correct. So what about I? So amoxicillin is your intervention. What was the comparator that we had in this one? Right, watching and waiting. If it'll go. And what about our outcome? Resolving the ear infection. So Does anyone want to go through their question? Did you guys write a question out too? Go for it.
Is resolving an ear infection with amoxicillin better than waiting and watching for 3-year-olds?
Everybody like that? I thought that was good, and it doesn't necessarily have to be in certain order, right? As long as you have all the information in there, you just need to know kind of what you're looking at. So mine may be written a little bit differently. In pediatric patients with ear infections, is amoxicillin more effective than watching and waiting for full resolution of ear infections? Same idea, right? Doesn't matter how you write it. This just kind of gives you an idea to help you take the case that you're presented with and make a question in case you need to look it up in the literature, which does happen. It may not happen now, but it will happen where you have something that you don't quite know and you've got to do a literature search and see, okay, what studies are out there? What can I find that's out there? And this is a really great method to help you hone in on what you want to search. Okay, so the next A is acquire. So we're using PICO for our search terms. So P, I, C, and O you will use in the databases. So they call them sometimes mesh terms. So you'll use that in each database to search. So yours would be maybe pediatrics, right? It would be your intervention, amoxicillin, or you could do beta-lactams. And then you would do watching and waiting. So you would actually use those as terms to search in the literature search. So that's what that helps you with when you actually go into like PubMed or Ovid, which we won't go into, but it's just a way to show you that you can use these terms once you think about them to actually implement that and use it in your study search. Okay, so this is kind of the longer section, the appraise portion. So now we're actually looking at the study design. So this is the hardest part that pharmacists will all tell you. This is the hardest part of what we do when you look at a study, is was this study actually sound? So if this study is not sound, does it really mean anything for my patient? No. If the study was designed poorly, it really does not mean anything for my patient, even if the result says one thing over another. So did participating patients have an outcome that's being assessed? So you actually need to look at some of these studies and read them. Sometimes they won't actually have a legitimate outcome being assessed. So death we care about, right? But do we necessarily care that blood pressure was raised by 2 millimeters of mercury? Do we care about that? No, right? It doesn't make sense. So we have to make sure that the outcome that's being assessed is actually meaningful. The next, what is being compared? So are we comparing apples to oranges? So there was a recent study, we talked about COPD together, right? With the spirometry a little bit. So there was a recent study that came out, and I told you that you have class A through D, right, for your severity. A is least severe, D is the most severe. And they compared a drug that's used in class B and a drug that's used in class C. Does that make sense? No. Is that really meaningful? Probably not, because we're comparing two different severities of patients, two drugs that are used in different areas of the disease. So that doesn't really make sense. So you have to look at things like that. Also, are we using the gold standard medication as the comparator? So are we comparing amoxicillin to watching and waiting? Or are we comparing amoxicillin to what's actually the standard that is normally done for patients that are pediatrics? Does that make sense? If you're just comparing it to something else that doesn't really matter, what's the point of the study? So the gold standard is really, okay, what is the actual thing that we normally treat this disease with? Was there bias in the study? So bias comes in all shapes and forms. So did they choose people? Did they randomize people? So did they randomly put someone in category A and category B? Or did they just say, hey, I'm going to pick you for category A, and I'm going to pick you for category B, and I'm going to pick the tall people for category A? So was there randomization? Because you can actually make a study that you don't randomize that's less meaningful, because there's potential bias that you just selected a certain group of people to be in one group versus the other. Blinding is another thing that we talk about. So blinding. So does the patient know which therapy they're getting? That's kind of your single blinding. Does the patient know? Double blinding is patient and the person who is evaluating the result of what happens with the patient. So double blinding is where you have nobody knows who got what. So nobody knows who got placebo and nobody knows who got drug A, and we're looking for the outcome. Because there could be bias, right? If you know that you got the intervention, there could be bias, right? So there's a big thing with blinding actually makes your study stronger. Same with randomization, makes your study stronger. If you don't have those, it's a little bit less meaningful in your study. Does anyone have any questions on this slide? Okay. So now we're going to go through an example of a study that I found with stealing trick-or-treaters. So the study design, so there were over 3,000 trick-or-treaters, and they entered 27 houses in Seattle from 5 to 9 p.m. So that's our patient population that we have. And our definitions, so they were either anonymous, so no one asked their name when they entered the door, or they were identified. They were asked their name and where they lived when they walked in the door. And they tried to compare who was more likely to steal more candy. I thought this was relevant. Okay, so all children, no matter what, were told not to take more than one piece of candy. So everyone was told that. And then there was a woman at each of the 27 places, and she chose which groups that children would be placed in. So when they came to the door, each woman in the 27 houses said, okay, there's either going to be a responsibility or an anonymity factor. So responsibility, either she put no child in responsible for the group, or she said, hey, you, the smallest child in the group, you're responsible that nobody else takes more than one piece of candy. So she did, either she didn't say that at all, or she picked the smallest person in the group and said that. Anonymity, so they asked everyone's names in the group, or they asked no one's name in the group. And then they compared them. So they excluded, so who did they get rid of in this study? So they said anybody with a parent, we're not gonna do that. Because if your parent's there, probably more likely to not steal candy, right? If your parent's watching you. And then really large groups, which they didn't define what really large groups meant. Okay, so here are our study results for the trick-or-treaters. So if you look at my bolded anonymous, the anonymous ones, which kind of makes sense, were more likely to steal candy, more than one piece of candy, than those that were not anonymous. But the big group here is when one child was in charge, more of them were likely to steal if they were anonymous. Blame doesn't go on you, right? Blame's on the small kid, right? That's what it was, right? So these are kind of the results of the study, and now we're going to look through and evaluate what we think about the design of this study. So do we think there's a high level of evidence of this study? You guys can kind of talk about these questions if you want. It might be easier to do that, and then we can break back and talk about it together. Does that work? So just kind of go through some of these questions and see what you think about this study.
That was part of the thing with the last piece of the study was the small child and the other
Is that like how they measure?
So that's looking at your hierarchy. So looking at your study design, what do you think? Do you think this is a good study? So do you think, is this a meta-analysis? No, right? But is this a case? Is this one case? No. So we're probably somewhere in the middle, right?
And my question was, were they like on a
You didn't get
random
that.
schedule to pick or was it up to the...
It was up to the woman.
Or you didn't have a control. I think that was a control. So identification is not like acts of like not yeah, but if they get something then you pick it up. The same problem.
Guys doing okay? Everybody doing all right? You guys doing all right?
Yep.
Okay, good. Good, good.
Higher level. This is kind of it's almost like the kind of like the first one after
How we doing? Everybody close to done or? Good? Good? Still working a little bit? Take your time. Take your time.
I think this might be the case control, right? But they're trying to remove barriers.
All right, let's go ahead and get started. We'll get through. Okay, so when we look at the level of evidence, do we think this is low on the case series or case report, kind of? Maybe a little higher than that, but is this a great randomized controlled trial? No, right? So it's going to fall somewhere in the middle of our evidence pyramid, right? So probably not the best evidence, but may not be just one case or one group of cases that we were talking about. So it's okay. We're not super thrilled about the study, sounds like. Okay, did patients have an outcome that was being assessed? What was it? Yep, whether they stole or whether they didn't was the outcome, right? So what percentage of them stole based on what group they were put into? How about what's being compared? So they had a couple things they compared, right? So they compared whether you were alone or whether you were in a group. They compared whether you had someone who was responsible, somebody who wasn't responsible, right? And they compared anonymity and you actually knowing what street you live on and your name. So they compared a couple of different things in this study. I don't think that's a bad thing. They had a couple things that they wanted to look at, and that was clearly defined. So bias. What kind of biases did you guys see? Selection, right? So a woman just randomly selected who would be in what group at 27 different houses. So 27 different women selected randomly whatever they felt, right? So is that the best study design? No, we'd rather have a more systematic approach to randomly selecting children into groups. What about blinding? So there was no double blind, right? So some people did not know. But the kids didn't know they were being evaluated, did they? They had no idea. So that makes the study a little more sound, right? The kids didn't know they were being evaluated. If you said to this kid, we're going to evaluate whether or not you're going to steal today, do you think they're going to steal? Probably not. So at least we have that going, but there wasn't blinding in terms of who was evaluating them for whether or not they were stealing. So we didn't know. And we knew whether they were in a group or not. And they knew whether they were anonymous or not. How about randomization? We sort of went over this. They didn't randomly select patients. So this study, we can say, okay, there's some good things with this study, but it's probably not the most sound study we could have ever made, right? It's not a randomized controlled trial. All right. Now we're going to go through generalizability, and then we'll also compare it to the case that we just went through. So, the definition of generalizability in layman's terms. How do I apply the results of this study to actual patient care? So, when I look at this study, can I take all of that and extrapolate it to patients that are outside? So, what do we look at for that? Are the patients representative of the normal population with whatever disease they're studying? Did they exclude way too many people? Did they exclude people with renal disease, people with blue eyes, did they exclude all these people that don't make a lot of sense so that you create this perfect little population to study? It happens. Sometimes they'll do that. And then you say, hey, that doesn't really relate to my patient who has heart failure, diabetes, all these other comorbid conditions. You can say, hey, that doesn't really relate as much to my population because we have a really healthy population here of 40-year-olds, and the patients that I usually treat with this are 70. So that's kind of what generalizability is. It's looking at the study and seeing, does this kind of match the patients that we usually take care of? So the inclusion and exclusion criteria. Who did they include is also important. Did they include the right patients? Did they include the patients that actually have the disease? Did they use the right gold standard test to determine whether someone has the disease or not? So was this patient diagnosed? We talked about, right, how to diagnose asthma with a spirometer, that you have to do the bronchodilator afterwards to see if they improve. What if they didn't test them that way and they just said, hey, our patients with asthma that we included have a history of asthma in their chart? Is that as good? Probably not, right? Versus someone who actually had the spirometry test while you're there to say that they have asthma. So you have to look at both who they include and who they got rid of. Those are your big markers for how does this really compare to my patients. And objective criteria for diagnosis I sort of talked about, that's the gold standard, right? Did they diagnose them with the gold standard? Or did they just say, hey, this person looks like they're breathing pretty hard, they probably have COPD, right? So was follow-up sufficient? So in our bigger trials, this becomes important. So did they follow a patient for death due to a therapy for 3 months? Is that as meaningful as following someone for 4 or 5 years to see if they potentially had died? Right? So you have to think about, is this follow-up period long enough to say that we actually measured the outcome sufficiently? Did most patients complete the whole study? So if you look at this study and 70% of patients dropped out and then they compared the 30% that are left, what does that mean to you? That drug may have worked in those 30%, but maybe those 70% dropped out because they had a horrific side effect and they can't tolerate the drug. So that's going to depend, right? That's going to be your decision. Am I going to use this in this patient if 70% of what bad side effects happen to these patients? Maybe you wouldn't use it, even if 30% may have benefited. So those are all things that you have to think about when you have your results of your study and you're looking, should I use this in my patients? So here's our practice. How can I apply the results of the trick-or-treaters to trick-or-treaters in Utah? Are they representative of the normal population of trick-or-treaters in Utah? No, right? There could be more parents with the groups, that was mentioned. Right? So it's probably not generalizable to our population here in Utah. They were in Seattle. There were 27 homes. Were they in the same neighborhood? We don't know, right? Could they all have been in the same neighborhood? Could they all have had no parents that were supervising? Was it a safe neighborhood? Was it not? There's a lot of things that we don't know. So it may not be generalizable to our population here in Utah. And if we look at the inclusion and exclusion criteria, so we got rid of large groups. I think large groups would actually make a difference. If you had really big groups, I feel like you could hide. Oh yeah, you're snatching more candy, right? Potentially. Larger groups, you can hide a little bit more. And then people with parents obviously makes a big difference, right? So I think that was probably an appropriate exclusion criteria, if your parents are there or not. And then who did we include, right? We sort of talked about that. We included people in this maybe one small neighborhood of Seattle. So that doesn't necessarily translate. Okay, so analysis of the results. So when we actually look at this, we analyze the results and say, does this matter? Same thing, were patients in the study better off as a result of this treatment? So did the patients actually see a benefit in this treatment, or was it 2 millimeters of mercury that we went up on blood pressure? Or did we see a significant difference? Is this clinically significant? So we talk about statistically significant, so maybe it is statistically significant that you increase the blood pressure by 2 millimeters of mercury. But is that clinically significant? Do we care about that as pharmacists? No. So you have to look at that when you look at the results. So they may say, oh, and the paper will write up in the end, they'll say, oh, this is great, we saw this statistical difference, but do I really care about that difference, is what's important. And does the intervention work better or worse for patients with different severities of disease? So do I see my Class A COPD patients doing really well, and then I see my Class Ds doing terribly? That would affect who you decide to treat with this. Right? So if they do an analysis and they say, hey, our group A, less severe patients did great, and our Ds just did horribly, then why would you use it in your D population? So those are things you have to think about when you're analyzing the results and applying it to your patients. So, again, trick-or-treaters in this study, were they better off as a result of the intervention? Did this bring awareness to trick-or-treaters and their parents about lying? Probably when they saw this study, they were like, oh my gosh, that's a lot of liars. And did this study bring awareness to the psychology of childhood behaviors? I can tell you the answer to that is yes. This study was done in the 1970s and is still brought up about childhood psychology and how the group mentality, the anonymity. So this actually was a significant study that looked into psychology of kids. So even though we may not have seen an effect directly in those kids, we don't really know, it added to the literature. Even though it wasn't the best study, we now kind of looked at this and said, hey, there's something about this, and they started to study it further. So it doesn't mean that studies are meaningless if they're not the perfectly done study, but maybe you'll say, hey, let's look into this a little bit deeper. So lastly, apply. How will the results of the study change the way you treat your patient? So your patient comes to the pharmacy window, your patient that's right in front of you. How does this study that you looked up compare to that patient that you're actually treating right now? And we do this all the time in the hospital. We'll apply studies to one individual patient. So things to consider, were the study patients, again, similar to my actual patient that's standing here in front of me? Were all clinically important outcomes considered? So did we look at all of the things that we think are important? Would death be important in this study and we didn't look at it? So things to consider, are the likely treatment benefits worth the potential harms and costs? That's something we talk about a lot. So what is the harm that's with this medication that you're potentially giving this patient, and does it outweigh the benefit? So then we won't use it if the harm outweighs the benefit, or does the benefit outweigh the harm? So if you look at these patients and we apply, so some of the important outcomes that we didn't look at was age, right? They didn't look at age at all. They didn't look at gender at all. I would have thought that may be a difference that you saw. What about a male person handing out candy, or a male person saying, hey, you can't take more than one piece of candy? Would that have made a difference? Maybe. So there's things that they didn't study that may have made a difference. And that's kind of how you would apply it. So you would say, okay, did we assess everything that's important? Maybe not. So maybe this doesn't always apply. Does this make sense as we've gone through all the portions of this? Or is there anything that's confusing to anyone? Okay. So we got through the research part. Now we're going to have a brief part about the clinical expertise and the patients. So clinical expertise, using a combination of the basic skills that you have learned with your clinical expertise to help with decision making. So that's the idea behind what it means. Healthcare professionals use their experience all the time to think critically about each individual patient and whether or not the best evidence should be used in that patient or not. So here are some examples for you. Example 1, a patient has a history of a heart attack and should be taking aspirin to prevent another heart attack. The physician takes the patient off aspirin indefinitely because they had a serious head bleed. So here's when you say, is it worth it, right? So the best evidence for this patient for preventing another heart attack would be to give them aspirin. But in this patient, we decided not to do it. So here's where clinical expertise comes in because the risk may be too great for this patient. Another one, a patient has high blood pressure and is on metoprolol. A physician stops the metoprolol because the patient has become dizzy and fallen multiple times. So even though this patient should be on something for their blood pressure, at this point, it's not worth the risk of them falling, breaking a hip, staying in the hospital, and potentially dying. So clinical expertise comes in all the time as a pharmacist, physician, whatever you are. We'll all be pharmacists, but patient preference is the last one. So this is one of my favorite quotes. This is Dr. Samuelson. He actually works at the School of Medicine. He's one of the pulmonologists here. And he said, there are many well-documented clinical trials demonstrating that medications do not work to their fullest potential in patients who do not take them. Essentially what we're saying is if this patient is not going to take the one with the best evidence, why would you give them the one with the best evidence if you could give them something else that may still work, right? So it really boils down to a combination of what does the patient want, what does our clinical expertise say, and what does the research say. So it's a combination of using all of those factors, not just one, what is the best evidence. So reasons why patients don't take their meds. Poor insight. So some of them don't think they have anything wrong with them. They're like, I feel fine. I have high blood pressure, but I feel fine. So I don't think I really have a problem. This is a big problem, is actually psych disorders. Patients don't realize that they have a psych disorder, and they really do. But that's one reason. Access to medications. So potentially the cost is too high. They can't transport themselves to get to the pharmacy on time. They're handicapped. They can't give themselves the inhaler. They're old. They can't manipulate the inhaler. They have Parkinson's disease. There's tons of different things like that. Adverse effects or fear of adverse effects. I'm sure we've all seen the commercials, right? Where they just list out every adverse effect. Of course patients are going to be scared to take them. Of course they are. Forgetfulness, that's a big one. They forget to take it. Inability to swallow tablets. So do we give them a liquid or do we just keep giving them tablets and we forget that they can't swallow or they don't tell anybody they can't swallow? Religion. So religious beliefs is one. There's so many more reasons, but you kind of have to, as a pharmacist, delve into that, right? Why aren't they taking their medications? And is it something that I can help with? Or is it something that we need to choose a different therapy for? Okay. So again, if you guys are intimidated by it, you can close your eyes again and raise your hand if you would always recommend using a medication with the best evidence. And now we have one, maybe. Right? So I hope today that I've convinced you at least that this is a conglomerate of things when you talk about evidence-based medicine, and it's going to be just an introduction to what you guys will do for the rest of your career. So no pressure. But thank you guys. You guys have been great. I really enjoyed it. So please fill out the evals honestly, because I want to do this for a living. So give me the best feedback you can get. Not the best, like good feedback. Doesn't mean it has to be good if I was bad.